Really delighted to introduce Dr. Dan Fried as well as Dr. Matija Snuderl. Just very briefly, Dan Fried is our head of target discovery and translational research. He has just an incredible background in both basic as well as translational cancer research, as well as in drug discovery and development, spanning both academia and industry. So we're very, very fortunate to have him at the Cordoma Foundation. Essentially, Dan's role, what does target discovery and translational research mean? Essentially, that means catalyzing and supporting research across the globe to identify new targets, so new aspects of the disease biology that could be targeted with drugs. And importantly, what's the translational piece? That means building the data packages that are required to understand how do you apply that insight to an actual patient. Like how do you actually build the rationale for a clinical trial that's going to be well designed and likely to be successful. In addition, as you might hear more about, Dan also is the director of our new lab, Cordoma Foundation Labs, which we'll talk a little bit more about. And then also really delighted to have Dr. Matija Snuderl here. Dr. Snuderl is a neuropathologist here at NYU, comes to NYU by way of Mass General, and has a deep expertise in precision medicine and has been pioneering new approaches for a variety of neuro-oncology indications, brain tumors, et cetera, to subclassify tumors into different subtypes that are clinically actionable. And what I think you're going to hear him talk about is how some of those approaches are actually bearing fruit in Cordoma in a significant way, which could potentially, in the not-too-distant future, help to influence and guide care. And I'll just mention that Dr. Snuderl is part of a multidisciplinary team that Dr. Sen has organized here at NYU, and that is being supported by the Bergman family, but also importantly includes Dr. David Zagzag and others who are working together to advance the understanding of the biology of the disease, and then as quickly as possible try to translate that into new treatments and new ways of guiding therapy. So without further ado, Dan, over to you.
Thank you, Josh, for the introduction. Hello and welcome, everybody. So I'm going to start by talking about precision medicine and Cordoma and really just try to kind of set the stage and lay a foundation for Dr. Snuderl's talk after mine. So I'm going to speak at a little bit more of a high level about precision medicine. I'm going to kind of start by introducing it and talking about what precision medicine is and how does it work. Because today's version of precision medicine predominantly utilizes genomic profiling. I'm going to go over the different flavors of genomic profiling tests at a high level that you can commonly consider. I'm also going to discuss some practical considerations for Cordoma patients based on a lot of the questions that Shannon and Andrea get at the foundation, and sometimes that I also get at the foundation from Cordoma patients that are interested in personalized medicine. And then I'll spend a little bit of time just going over how our research efforts at Cordoma Foundation and also elsewhere are advancing the outlook for precision medicine in Cordoma. So personalized or precision medicine at its core involves matching the right patient with the right drug at the right time. And it kind of moves away from a one-size-fits-all approach to treating cancer by the body organ in which it began, to instead focus on the specific molecular profile of Cordoma and the molecular alterations that are fueling cancer growth. So it considers this to be of utmost importance rather than the anatomical location that the cancer began in. And as I alluded to just a moment ago, it typically utilizes genomic profiling currently to identify biomarkers that can guide specific targeted therapy or immunotherapy options. So precision oncology really came of age around the turn of the century when a number of notable success stories really kind of firmly embedded molecularly guided therapy into the clinical treatment paradigm. And these success stories were really new and revolutionary in that they targeted a specific molecular alteration in the tumor rather than kind of trying to blast it with chemotherapy, as Dr. Cote alluded to earlier today. So for example, in 1998, the HER2 targeted therapy trastuzumab was approved for use in breast cancers that have a mutation that results in the production of an unusually large amount of a protein called HER2. A few years later, in 2001, the Abl kinase inhibitor imatinib was approved for a certain subtype of leukemias that harbor the Philadelphia chromosome that results in the production of this BCR Abl fusion. And then in 2004, the EGFR targeted inhibitor gefitinib was approved for non-small cell lung cancers that harbored mutations in the EGFR gene. And so collectively, these examples and a few others established a new paradigm that focused on understanding the range of DNA mutations that are responsible for cancer growth, and then developing drugs that are targeted against each of those mutations. So just to illustrate the potential power of precision oncology, this image here shows a 38-year-old melanoma patient with widespread subcutaneous metastases. This patient had failed multiple lines of therapy up until this point, and was probably weeks away from death. And he got genetic profiling done on his tumor. And the genetic profiling test detected a mutation in the gene called BRAF. And at this time, BRAF targeted inhibitors were in clinical development, so the patient enrolled on a clinical trial and received a BRAF inhibitor, and 15 weeks later, you can see that by and large, the subcutaneous metastases had almost completely disappeared. So this targeted therapy that he received, which really was only possible because of that genomic profiling that he got done, resulted clearly in an improvement in the quality of life and halted the progression of his disease for a significant amount of time. So success stories like these resulted in kind of an explosion in a number of companies and platforms in the 2010s that sought to firmly embed genomics-guided precision oncology into the clinical treatment paradigm. I'm showing a few examples here, but by no means is this slide exhausted. So what are the different types of genomic profiling that you can get done? So to kind of understand this, we have to look at a chromosome, zoom in on a segment of the chromosome, and if we kind of look at your DNA, a segment of your DNA, there are a number of genes that are separated by so-called genomic dark matter. And so what whole genome sequencing does is it reads that entire sequence. So that's one type of test that you can get done. And then there's whole exome sequencing. And exome sequencing basically looks just at the genes. So it reads the sequences of the genes. And then there's another type of test called targeted sequencing. And what targeted sequencing does is it looks at a specific subset of the genes, typically that are recurrently mutated in various cancers. And it just reads those to look for potentially actionable mutations. So there are numerous trade-offs to each approach, and I think Dr. Snuderl is much more of an expert in those trade-offs than I am. But just to maybe try to provide a few examples of the trade-offs that might be relevant to a patient, a targeted sequencing panel will analyze something on the order of about 500 genes. So that's kind of the coverage that you're going to look at. It has very high sensitivity in a turnaround time that occurs within a clinically actionable time frame. So you get the results within about 2 weeks. Whole exome sequencing technology has advanced considerably in recent years and has really closed the gap on targeted sequencing. So pretty high sensitivity, also a very quick turnaround time, but you're looking at about 20,000 genes when you talk about whole exome sequencing. And whole genome sequencing, you get much more information. The turnaround time is a little bit slower. So really, most precision oncology tests that you can order in the clinic these days are targeted sequencing or whole exome sequencing, by and large. So targeted profiling panels are limited and biased in their gene coverage. So I think it's important to note that. And they're also they've been optimized for a few common cancer types. Okay, so most of the targeted profiling panels, but not all, have kind of been developed for carcinomas, for more common cancers, not sarcomas like chordoma. So due to differences in disease biology, targeted panels can potentially miss actionable alterations. Whole exome sequencing, on the other hand, provides more information and has become increasingly practical in recent years. So if you're a chordoma patient and you're considering getting genomic profiling done, if it's possible and practical for you, I would recommend strongly considering whole exome sequencing over a targeted panel. So some practical considerations for chordoma patients. So who should consider genomic profiling? So if you have advanced disease, if you have recurrent or metastatic disease, and you are in need of a systemic therapy option, you should consider whether the testing is right for you. And this is something that you really need to discuss with your oncologist to weigh the pros and cons and make the best decision for your individual situation. But typically what's needed is ideally a new or a recent tumor sample, but you could also use an archival tumor sample from a past surgery or biopsy. And there's a new technology called liquid biopsy that Dr. Cote mentioned earlier today, and Dr. Snuderl might cover in his presentation. That's becoming more mainstream, and so there are opportunities for liquid biopsies as well. Are the test results needed for enrollment in clinical trials? It depends. So it really depends on the trial. You have to check the eligibility criteria for the specific trial, discuss it with your oncologist to understand whether molecular profiling or genomic profiling is required for enrollment on that trial. But in general, the results of this testing can help point to personalized clinical trial or off-label or compassionate use opportunities. And in terms of clinical trials, it can also, you can also consider precision oncology trials or basket trials that are agnostic, essentially, as far as the type of tumor that you have. So they don't care if you have chordoma or lung cancer, pancreatic cancer, brain cancer, colon cancer. What they care about is whether you have a specific mutation. So on that clinical trial, they're testing a drug against a specific mutation. If you have that mutation, you can enroll on that trial. So those become possibilities with molecular profiling. Are the test results guaranteed to identify a biomarker for personalized therapy? Unfortunately, no. So oftentimes, this is particularly true for chordoma, no actionable mutations are found, at least in terms of our current understanding today. Even if you have an actionable mutation, it's possible that therapies could be inaccessible to you. So for example, you might not be eligible for a clinical trial. And then, what works for some people doesn't work for others, okay? So 2 chordoma patients with the same genomic mutation that receive the same therapy, one might benefit and the other might not. So that's important to note. And so most chordoma patients today have not benefited from genomics-guided precision oncology. So if we look at the published studies, the published molecular profiling studies of chordoma tumor samples, only about 10 to 15% of chordoma tumors, based on those studies, have a mutation that would indicate a clear off-label drug opportunity or clinical trial opportunity based on data from other tumor types where that mutation is known to be associated with benefit from a specific targeted therapy. So a minority of patients with today's science might have sort of a clear choice, or guided, care can be guided from molecular profiling. So this contrasts to non-small cell lung cancer, where over 2/3 of patients have a mutation that can guide care. And so that's quite a difference there. So how can research maximize the number of chordoma patients that can benefit from personalized medicine? Well, we need to grow our understanding of chordoma biology at a pace that matches advances in technology that are being made in precision oncology testing, in order to identify new types of therapeutic vulnerabilities, understand which patients are the most likely to respond to those therapies, and then evaluate or predict the actionability of mutations of unknown significance that occur in known cancer-related genes. So each of these areas are kind of related and mutually reinforcing. So in terms of predicting the actionability of mutations in cancer-related genes, as I mentioned a moment ago, a minority of patients, of Chordoma patients, will have a genomic profiling result that will kind of guide care. So what do the other patients do? Well, in the absence of sort of recognized biomarkers, there are potentially actionable alterations or variants of unknown significance in cancer-related genes that can suggest possible therapeutic opportunities based on emerging science. So these are typically listed near the end of a profiling report and should be discussed with your oncologist. I am not a medical oncologist, but just from sort of a scientist's point of view, I'll give you an example of how this thought process might work. So this is a sample Tempus report from an imaginary patient with prostate cancer. And let's just pretend they don't have any clear biomarkers that would guide care. So we go to the end of the report, and I would look at the potentially actionable mutations, the variants of unknown significance. And so from a scientist's perspective, what I'm looking at here is, okay, I see copy number gain in an AR, in the androgen receptor. And I know from the science that copy number gain in AR is associated with resistance to abiraterone. So maybe that's not the best therapy for a prostate cancer patient that has copy number gain in AR. But look, they have a rearrangement in TMPRSS2 ERG. So science has shown that that might promote sensitivity to PARP inhibitors. So maybe that's an approach that you should discuss with your oncologist. So you can start to kind of try to get information when there otherwise really isn't a clear option from these potentially actionable mutations or variants of unknown significance that can potentially guide care for you. And so as we do that, if we look at the mutations that are potentially actionable that have been reported in profiling studies for chordomas, now up to 40% of patients might benefit from genomics-guided precision oncology, if we assume that all of those mutations are pathogenic, which is certainly not the case. This is probably an overestimate. But the point is that the slice of this pie starts to grow a little bit larger as we learn more about the science of chordoma and potentially actionable alterations. And so just to give you an example of how we're approaching this type of problem at the Chordoma Foundation, this is data from a drug screening program collaboration that we have with Dr. Cote at MGH, who was here earlier. And we looked at a subset of chordomas that have a mutation in a gene called SMARCB1. And what we found was this mutation created sort of a ripple effect vulnerability in another process elsewhere in the cell that could be exploited through ATR inhibitors or gemcitabine chemotherapy. So this is data from mouse models of chordoma. And you can see that if you treat those mice with an ATR inhibitor or with gemcitabine, you see significant reduction in tumor growth or even tumor regressions. On the right there, tumors in 3 out of 7 mice that were treated with gemcitabine had their tumors completely disappear. The other 4 tumors regressed significantly. So we're excited about that result. And importantly, this efficacy was not seen in chordoma models that did not have a mutation in SMARCB1. So we're seeing this differential sensitivity that's tied to a specific mutation. So I should note, it's important to repeat this experiment in more models, and we need to do complementary experiments in our new lab to ensure robustness of this result and make sure that we're kind of barking up the right tree right here. But we're excited about this kind of thing, and we're also extending these observations to genes that are related to SMARCB1, that have related biology that are also altered in chordoma, to understand if more chordoma patients could potentially benefit from a similar approach. So how do we keep growing this slice of the pie, the blue slice of the pie, even larger? Well, we have to understand more about chordoma biology. We have to kind of peel back different layers of that onion to really understand beyond the genome what types of processes might be contributing to tumor growth. So much like a topological map combines information from multiple different data layers, and only when you put all of those together you get a comprehensive picture of a particular piece of land. Tumor biology is governed by multiple different processes that are all integrated and all co-conspire to drive things haywire and result in this dysregulated growth. So opportunities for personalized medicine exist within each one of these layers, And if we combine more layers, we get a fuller picture. And we reveal potential targeted therapy opportunities, personalized medicine opportunities. So some precision medicine tests that are available today are already doing this. They're already starting to combine multiple data layers to provide a fuller picture. For example, Tempus XE combines genome sequencing and transcriptome sequencing. And we're also working towards this in our lab, in our new lab. So we have a project right now where we're trying to understand which Chordoma patients are most likely to respond to EGFR inhibitors. So as some of you may know, inhibitors of EGFR, including afatinib and cetuximab, have long been considered an attractive therapeutic approach in Chordoma. And that has motivated 2 phase 2 clinical trials that are ongoing right now in Europe and in Texas. And what we don't know is which patients are most likely to respond, because EGFR is not mutated in Chordoma. So it's not like lung cancer on that earlier slide that I showed you, where lung cancer patients with an EGFR mutation get gefitinib, the EGFR targeted inhibitor, and they respond. It's not that clear cut. So what we're doing in the lab is we're taking as many Chordoma cell lines as we can, we're treating them with EGFR inhibitors, and then we're also doing genome profiling and transcriptome profiling. We're going to take all of that data and combine it and throw it into a computer to generate a predictive model of EGFR inhibitor sensitivity. So who's going to benefit, who's most likely to not benefit. We're going to validate and refine that model in our drug screening program. And ideally, we may be able to validate it on patient samples from one of those clinical trials. And the idea would be to try to identify a clear-cut set of biomarkers that might eventually be able to guide care. So this is one example of the type of thing that we're working through in the lab right now. But at a bigger picture, we have a high interest in identifying and validating new types of therapeutic vulnerabilities. So our target discovery initiative at the foundation has a number of projects, both internal and external, that seek to understand the range of Chordoma dependencies, piece together these different layers of Chordoma, and then also understand how Chordoma cells interact with immune cells, for example. And so these studies that we're involved in, as well as many others in the Chordoma research community that we're not directly involved in, are really identifying some attractive therapeutic approaches that we have a high interest in validating in our lab to understand where personalized medicine opportunities might exist, where the next generation of personalized medicine opportunities might exist for Chordoma patients. So together, these 3 things, for example, the Target Discovery Initiative, the EGFR project, and the SMART-B1 project that I just told you about, I think can really start to grow that slice of the pie a little bit bigger, hopefully, so that we can have more options for Chordoma patients. So that's kind of what we're doing right now. I will take questions after Dr. Snuderl's talk. We'll take questions together. Thank you for your attention.
So thank you everybody for coming. It's a real pleasure to be invited. It's such a nice event, and I would really like to thank Cordoma Foundation for organizing this event, and all of you for coming. It is always hard to work on a rare disease, but it's much harder to have a rare disease because you just feel that there's not enough people around the world who care about it, and it's great to see how many people who actually care about Cordoma in this room and making a real difference, and it's great to follow Dan's talk on precision medicine. I'm going to give you a very high-level view on what is happening in precision medicine, what may be applicable to U.S. patients, and a little bit of a glimpse of what I hope is the future of precision medicine for Cordoma patients. So we're going to be talking about what molecular tests are available now and how informative they may be in Cordoma. How can you get your tumor tested, and should you get your tumor tested? Is it going to give you more information, or is it going to confuse you? We're going to talk briefly about insurance coverage because, that's what healthcare is a lot about the money. We're going to talk about molecular testing, what first and what not to do. I'm going to briefly mention germline testing because that's one of the questions that I get asked from time to time. I'm going to talk about molecular testing in recurrent Cordoma. I'm going to touch about the liquid biopsy and minimal residual disease monitoring, and then what is on the horizon in a precision medicine for Cordoma, because as Dan mentioned, there aren't that many targets that we see. So I don't want to elaborate on it, but this is sort of this elusive idea of a precision medicine that we can target our treatment not necessarily to histological pathology, it is just an example of brain tumors, but more based on specific mutations. And that's what was shown in the previous talk. But over the last few years, we have really worked hard to develop a state-of-the-art precision medicine program here at NYU. Have the largest FDA-approved panel for DNA next-generation sequencing. We're the first to implement whole genome DNA methylation profiling in diagnostics and have one of the probably the largest fusion detection platforms in the country. However, despite all these tests, still a large number of tumors, and particularly Codomas, remain without a target that we could actually pinpoint the development of the disease, and most importantly, potential targeted therapy. There's another problem, and that's what I have termed a long time ago a BRAF V600E paradox. When I was in medical school, I had this fantastic teacher who believed that all the pathology will be obsolete. We'll take the tumors, we're going to grind them, send them into machines, they're going to give us the mutations, and mutations we're going to point to the smart drugs that we're going to target it with. But it's not only enough to know the mutation, the context matters. BRAF V600E is one of the most common mutations in cancer, but it's present in one of the most malignant tumors of a human body, such as malignant melanoma, but also in some of the most benign tumors of a human body, such as pilocytic astrocytoma. And there is a large number of cancers in between that can be driven by this mutation, some of them more malignant, some of them less malignant. So what I want to point out is that mutations are context specific, and just that you see the mutation may not be enough to predict whether how badly it's driving the tumor and how well it can also be targeted. So we always have to look in the mutations in the tissue-specific and a cancer-specific way. There are many different types of molecular pathology testing. There are in situ methods, for example, immunohistochemistry, and it's well known that brachyurin is a perfect example of a diagnostic test to make sure that the tumor that you're dealing with is indeed chordoma and not one of the histological mimickers. Then we have DNA and RNA next-generation sequencing, epigenetic analysis, and others. Then there's a panel of the tests. How big the panel should be. There are targeted assays that have a single or limited to a few targets. Then small sequencing panels up to 50 genes, and then large panels that have more than 50 genes. And it will become a little bit more obvious in the next slides. Why did I choose 50 as the border between the large and small? Then we have whole genomes, exomes, transcriptomes, and methylomes that look at the entire coding or the entire transcribed part of the genome or expression. But then there's also what is the purpose of a biomarker? Is the diagnostic biomarker? Does it answer the question, is the tumor that the surgeon took out actually a chordoma, for example, brachyurin, or DNA methylation classifier, or a prognostic marker? Is it tell us what is the risk of recurrence? We know that it's a chordoma, but how high is the risk for that particular patient that the tumor will come back? Or is it a predictive biomarker that will tell us, will this tumor, as Dan alluded to, respond to a therapy? And of course, the therapeutic targets that would help us to point to a specific target that we can use to treat chordoma. And then a lot depends also between the type of a test and what kind of material is required. Archival pathology tissue, which is traditional formalin-fixed paraffin embedded, is now sufficient for most of the assays. Over the many years, we have worked hard to move from the need of having a snap-frozen tissue, which is not always available and from many patients, to really move to be able to use the archival tissue. But snap-frozen is still a very important type of a tissue for very high complexity molecular assays. Metabolomes and proteomes just don't work on formalin-fixed paraffin embedded tissue. Another type of a material is cryopreserved, where the cells that are taken out of the body are actually still able to grow and are able to be sent to another labs that do drug screening, sensitivity screening. They can be used for patient-derived models in mice, and that we can test drug sensitivity. So these are all different types of aspects that we have to look into when we are thinking about what kind of testing we want to perform in Cordoma. So how do you get tested? Well, it's what I call local. Wherever the surgery was performed, you kind of check and you talk with your treating physician, oncologist, or surgeon, what type of molecular testing is actually available at the institution where your surgery was performed. However, most institutions, that includes academic institutions, they prefer either small or very limited panels that are not really informative for chordomas, because as it was said in the previous talk, they were developed for so-called big cancers, lung, melanoma, breast, and not necessarily for chordomas. So the genes that are present on those small panels really rarely have anything to do with a chordoma. And then the outside, there are numerous commercial players, industry that can do almost any type of a test. But of course, in there needs to be a proper interpretation that puts the mutations that were found in the context of a specific tumor, such as Cordoma, whole exomes, large panels, transcriptomes, and genomes. So the interpretation needs to be tailored to Cordoma biology, and it's good to speak with somebody who actually understands Cordoma biology. And if it is an academic place, again, it should be an academic place that has a specific expertise and interest in Cordoma, for example, like we do, that can do not only the right testing, but also interpret it in terms of Cordoma biology. So the controversial question is, should every Cordoma be tested? Well, here's a researcher and a clinician in me is, not in every, because there aren't that many mutations in Cordomas, it's questionable whether every Cordoma at the first time should necessarily be tested. For the research purposes, absolutely. We need to learn more about these tumors, but it doesn't really make sense to do small panels that are not informative just for the purpose of testing. So the diagnostic or prognostic yield in the initial setting might be relatively limited. But we do need more tumors to be tested for research to identify the drivers. However, recurrent tumors, progressive tumors, aggressive tumors with high proliferation should definitely be tested to identify whether they're associated with a high risk of recurrence and whether they're potential targets for therapy. Although that piece of a pie is relatively small, as was shown in the previous talk, it is not zero. So if you have a progressive or aggressive tumor, you really need to look for potential targets. The insurance landscape, the payers, it's evolving. So you may have been puzzled at the first time when I was talking about 50 genes. Is this magical line, that's 50 gene, that defines whether the insurance is going to pay for molecular tests or it's not going to pay for molecular tests? Most of the payers pay for the tests that are less than 50 genes. Most of the payers do not pay for the tests that are more than 50 genes. So why is it 50? I don't have a good answer for that. It's just one of those random healthcare policies that was developed a long time ago. And then you have a whole exome, whole transcriptome, whole genome, and whole everything, which is always considered experimental by payers, and it is never covered by insurance. So that's where really foundations and philanthropy really come in to be able to cover some of these more advanced tests. And the sad thing is that the panels that are paid for by insurance are largely not informative for Cordoma. I want to spend a little bit talking about the germline testing. We often get asked, if I have a Cordoma, what is the risk for the other members of the family? What is the risk for my children? And Cordoma is overall considered a sporadic tumor. So germline genetic testing, patient and family members is usually not required unless there's other stigmata and other family members that are affected either by this tumor or other tumors. So that's really something that's best addressed with genetic counselors to go over detailed family history, patient history, and discuss whether there is a need for further genetic testing. Should it be performed repeated testing? Should a recurrent tumor be retested? I would say Cordoma risk factors are poorly understood. We know something from the histology, anaplastic and aggressively looking tumors that should be tested, high proliferation marker by Ki67 or DNA methylation. So we don't really know why some tumors recur and some do not know. So is it a recurrent Cordoma or a new Cordoma? It's also a good question. So I would say in the setting of a recurrent tumor, of a new tumor, molecular testing should be performed to basically answer a question. Does the patient have a second Cordoma, or is it a recurrent tumor? Because those have different outcomes. And molecular testing can provide those answers. We can compare mutations between the first tumor, the second tumor, and see whether they're related to each other. So recurrent tumor can also contain some risk factors that the primary tumor did not have, and it may become more aggressive than the previous tumor was. So that's why recurrent tumors should probably always be tested with the appropriate size of the panel. So what are the current challenges in identification of genetic drivers of cancer? So first, clinical panels, as was said before, they were not designed for Codomas or for rare cancers in general. So they often fail to identify drivers and therapeutic targets. Many Codomas still lack molecular drivers. It's one of those tumors where we still do not really know what drives it. Clinical panels are predominantly focused on coding regions of the genome. I'm going to talk a little bit more about it. And cancer driver genes are often tissue, context, development dependent, and we know very little about the development of Codomas. This is a study that was published just a few years ago, and this may be a little bit difficult to show, but it's basically a mutational analysis of the spinal Codomas, and it doesn't really matter what the genes are here, but I want to point out to you is how few of them actually have any mutation detected whatsoever, and if you can see here, the number of mutations per tumor, 1, 2, 3. Those are very few mutations that we find in a tumor, and many of the tumors, we don't find anything. If you compare that with lung cancer, breast cancer, or colon cancer, those are tumors that have hundreds, sometimes thousands of mutations during the development. So Codomas are really low mutation burden tumors, and in many, the actual molecular driver remains unknown. So how is it possible? Well, and what do we do with it? Because if we don't have a targets, there's really no way for us to develop better therapies. There's some new prognostic biomarkers that are emerging. One of them that we are very excited about is DNA methylation. We and others have been working on the epigenetic landscape. DNA methylation is an epigenetic mechanism. How to identify high risk and lower risk Codomas. And this is a group from Toronto, from Dr. Zada, that showed that there is a hypomethylated group, cluster 2, and then immune-infiltrated group in a cluster 1. You can see here immune cells present here. And it was shown that the cluster 1 is associated with a more aggressive behavior than the cluster 2. And these are very intriguing data that highlight the importance of molecular classification, and we and others are working on further substratify with DNA methylation which types of Codomas are going to be more likely to recur and which of them are less likely to recur. Also, which of them will respond to radiation, and which we heard a lot about today, and which of them will not. But we need larger cohorts, and the Cordoma Foundation has been instrumental in bringing researchers together to create those large cohorts that can statistically, with a strong statistical power, identify the prognostic biomarkers. We need to integrate with other factors. As you have all experienced, not all neurosurgeons are created equal, so there's a lot of bias towards how much of a tumor was removed during the initial surgery, so that also has to be integrated together with the molecular markers. Is the tumor recurring because it was a lot left behind, or is the tumor recurring because it's really naturally very aggressive? So we really need to have a better understanding of biological mechanism. I want to quickly mention the topic of liquid biopsy, something that I'm very passionate about it. You all know that liquid biopsy is basically the way to follow the tumor through the fluids, either urine, blood, or CSF, and then looking either circulating tumor cells, circulating cell-free DNA, or other modifications, either for a response of therapy in real time, understand the evolution of the tumor, or resistance mechanism. This is a nice study that was published by folks at Johns Hopkins, although a little bit overselling how useful it is right now. And you can see how the tumor here can be detected in the peripheral blood after the surgery disappears, and it's followed as monitoring, and nothing is present on the imaging. Their test, however, requires that there is a mutation identified. So this is great if there is a mutation that you can follow, but if there's a tumor that is without a mutation, then there's really nothing follow with this approach. But there are some exciting new technologies that can overcome this limitation. Here you see a patient that was followed with a local recurrence, then eventually when it spread with metastasis, it really increased the burden. The advantage is that we hope that liquid biopsy is going to provide a more accurate assessment of a tumor burden and identify the recurrence before it shows up on imaging. So what is next in precision medicine? And that's something that we've been working here. It's the question of 3D genomics, where we want to look beyond the sequence. So you all know that DNA is basically a code. It's a code of letters. It's like a string that has A, T, C, and G's on it. But DNA is not, it's not linear, right? That the amazing information is actually packed very tightly in the nucleus, as it's shown on the right. So if you want to have you want to imagine it, it's like if you take the entire New York City subway system and packed it into a suitcase, right? Which is sometimes feels like that, right, when you're traveling. So that's how really DNA is organized. So that means that things that are really far apart on a linear scale actually can get very close together when you pack everything together in the nucleus. And what happens in cancer is that those structures in a 3D actually get shuffled around. So you can have changes in a 3D architecture of the nucleus that will lead to changes in the behavior of the cell without any mutations being present. So the sequence of DNA is really just the tip of the iceberg, and we know that that tip of the iceberg is really not that informative in Cordoma. There's a structural variation, gene regulation, and a higher level genome organization that can identify interactions that we previously didn't know about it, and they seem to be very important, at least from our research, in Codomas. So what happens is, when you have an oncogene, even if it's not mutated, and you have an enhancer that drives activity of that oncogene, under normal circumstances, they may not be close to each other in a normal cell. What happens in tumors is that those two get actually brought together, the disappearance of the loops in between, and then the enhancer that was far away originally can actually start driving the oncogene. But if you just sequence it on the exome or transcriptome or even genome, you would never know that, because the interaction between them is in a three-dimensional space, not in the linear space. So this is something that we are exploring here at NYU, using these 3D genomic approaches to identify molecular drivers in chordomas that otherwise lack mutational drivers. So that's why we hope that those chordomas that are empty and there's no mutational variants in them are actually driven by these 3D reorganizations. So overall, I hope we showed you that precision medicine does enable identification of potential therapeutic targets. Tests vary in size and targets. Insurance companies do cover the tests, cover the costs of the panels that are usually of limited utility in chordoma. Recurrent chordomas should be analyzed to dissect the progression of the second new tumor. Germline testing is not universally necessary, but it does depend on other factors. And DNA methylation liquid biopsy represent novel prognostic and follow-up biomarkers. And what we hope is that utilization of 3D genomics holds promise for the identification of novel drivers and therapeutic targets in chordoma. There's a great team, it's Dr. Sen, who's been really breathing life into the idea of building a comprehensive multidisciplinary chordoma program here at NYU, and my partner in crime, Dr. Zagzag, who has been working on the very mechanistic drivers of chordoma, and of course many other people, Dr. Galbraith, who has been our chordoma research scientist, and many scientists, technicians in our lab, and of course our funding sources, generous support with the Bergman Family Foundation, Chordoma Foundation, and others who help us bridge that gap where the NIH does not really have that interest in these rare cancers, and it's really been a great team effort. And we'll be happy to take any questions. Thank you.
I'm not sure if you are the guys to answer this, but while you were speaking, I thought of some patients have been doing cryotherapy or cryotherapy, I'm not really sure, where there's freezing and ablation, and do you guys know anything about that? Uh-oh.
I'm just a scientist. I'm sorry. Matija?
I'm just a pathologist. We have Dr. Sen here, who is a preeminent neurosurgeon. Maybe he can comment on that.
Oh, I'm not answering the question. I'm just a patient. I have a different question.
That's a great question. I can answer that. 1 second, Josh. So the mice without the tumor, we order from a general provider. But the tissue, the tumor tissue that we get, that we implant into the mouse to grow tumors in the mouse, that comes from our tumor donation program. So patients that contribute to our biobank, our tumor biobank, in some cases in the past, and Joan has really driven a lot of this before I arrived at the foundation. If we get fresh tumor tissue, and we know in advance that there's going to be a surgery, we can arrange to have that shipped to the company that we do all of our mouse studies with. And they can take that fresh tumor tissue that was overnight shipped, implant it into the flank of a mouse subcutaneously. And sometimes it works, sometimes it doesn't. But if it grows tumors, then we can start to expand that and bank it. And then we have essentially a renewable resource of tumor tissue directly from a patient's tumor that was implanted into a mouse that we can use to model drug response and test therapies in our drug screening program moving forward. And studies have shown that these so-called patient-derived xenografts are very accurate and stable over time generally, so they don't become inaccurate. So they're very high-fidelity models that mimic the response that a patient has to therapy in the clinic. So published studies have shown that if a patient responds to a therapy, the cognate mouse model that is treated experimentally is likely to respond, and vice versa. So these are very high-fidelity models that we can use to explore therapeutic response in chordoma. Chandra.
Which one is easier, to grow a patient's tumor in a mouse model or in vitro on a dish, so that you can test out, like quickly, say person X has surgery, and for a chordoma, they want to see what happens to their tumor down the road.
Yeah.
And they decide that we want to have it grown so that, God forbid, the tumor comes back in 3 years, 4 years. What options do we have? Is that something in the foreseeable future that we will see? a patient can direct that, and then that is a mouse model necessary, or can an in vitro and a dish culture enough to test different drugs and to find out the variations that you all talked about?
It's a great question. So as far as ease of establishing the models, that's something that varies widely from cancer type to cancer type and the type of model that you're generating. So generally, the more aggressive the chordoma tumor is, the easier it will establish as a cell line cultured in plastic or in a mouse. As far as whether it's easier to establish a mouse model versus growing cells in a dish, I'm not sure that's really been systematically looked at. Joan, you may know from your prior experience whether anybody has, but as far as I know, I don't think it has. But both of these can be done. Generally, cells grown on a plastic dish are easier for technical reasons to manipulate, but they're not quite as high fidelity as patient avatars, as models of a patient's disease as a PDX is. But there's another option. There are what are called X-Vivo approaches, so things called tumor organoids or explants that are essentially miniature versions of patient's tumor that are grown in 3 dimensions in dishes that kind of combine the best of both worlds, from cells that are grown in a plastic dish and tumors that are grown in mice. So tractability, technical tractability and experimental tractability, and accuracy in terms of their representation of a patient's tumor and the biology of a patient's tumor. And there are a number of companies that are exploring organoids and PDX models as precision medicine platforms. And what I mean by that is, can you take a patient's tumor, to your question, implant it in a mouse or generate these miniature tumors called organoids, treat them with a panel of drugs to identify which drug is the most likely to work for that patient, feed that result back to the doctor, and use that to guide care. So there are a number of companies that are being developed that have the ability to do that. Mouse models generally cannot be established within a window of time that is relevant for guiding care for most cancer types. They take a long time to establish, but organoids oftentimes can be developed fairly quickly and screened against a bunch of different drugs. And there are regulated laboratories, CLIA-regulated laboratories that are able to do this. It's something that we're actually exploring for our drug screening program as a future potential option, where we might be able to get tumor tissue, implant it into a mouse, and not only generate a model for our PDX model repository, mouse model repository for our drug screening program, but also potentially screen drugs against that to identify therapeutic options. And the reason that this could be particularly valuable for chordoma patients is because what Matija and I were talking about, there aren't a whole lot of mutations that are typically detected by genomic profiling tests or other tests that can be used to guide care. And even when they are, not everybody responds, right? So tumor biology is just very complex. And so functional assays like this can be used to potentially guide care. And that's going to be, I think, a significant part of the future of precision oncology.
Can I just quickly add one more thing? Another exciting thing that's happening is, because there's problems with mouse models and cell lines and organoids, is the tumors on the chip. So we and others have developed models that you can basically make these high throughput chip models, in which you basically take the cancer and put them on a chip and do a very high throughput screening in a really quick time. So the idea is to have that answer before the patient would even start the therapy, and then you have to match it, of course, with the molecular profile to see which drugs you would use for the screening.
Is it worthwhile, like, will there be a day when we say that if I'm planning to do surgery on a patient, is it worthwhile to save a certain portion of the tumor and freeze it to be sequenced later on, or to do profiling later on, say the time arises? How long are those tumor cells viable to be examined like that? Second thing is, if they are grown in culture, how many passages do they retain their fidelity to the original tumor?
I'll take that real quickly and then pass it to you. So for sequencing, the cells, as far as I know, correct me if I'm wrong, Matija, don't have to be viable. So as long as things don't degrade, in principle, it should be fine. As far as how the number of passages, that varies on a case-by-case basis, but it's something that you have to be aware of, sort of drift away in losing that fidelity. So ideally, you would do that sooner rather than later. Sorry, I think I forgot the third part of that question. Go ahead.
I think in general, like every tumor should be banked, so it's available for future studies. Even if everything goes well and you don't need it, I mean, your tumor can contribute to science. The second thing is there are different ways how to freeze things. If you just snap freeze it, you're going to kill the cells, right? There's a way how to cryopreserve them that you actually freeze cells, but you keep them alive, right? So in the meantime, you can do all the sequencing, identify the potential target, then thaw the cells, put them in a model, and test drugs specifically with knowing what targets you're going after. So I think in addition to having a pathology tissue and snap frozen tissue for things like metabolome and phosphoproteome, something that we're going to try to build in is cryopreservation, so we can save cells frozen down, viable, so they can be thawed and used later on if the tumor recurs or if we need to identify the marker. So I think that's one of the ways how we can go about it.
Are there ways that patients can request that if they're having surgery?
Yeah, I mean, that really depends institution to institution, and I think it's always good before going for surgery to actually see how the tumor can be preserved and saved for future studies. I would say most of the Cordoma surgeons are located in large academic centers. That being said, it does not mean that those academic centers actually have the capacity to properly store the tissue. So we fight with it all the time that, for example, the tissue is decalcified. And decalcification is a process that removes the calcium, obviously, from the tumor. What it does, it completely ruins DNA and RNA, and we cannot do any further molecular studies with it. So at minimum, we always argue, try to preserve some tissue without decalcification so we can at least properly sequence it. If you can do more, try to freeze a piece of tissue, and if you can do even more, try to ship a piece of live tumor either to something like Cordoma Foundation or cryopreserve it at your institution so we can use it later on. So those are things that, it's hard to think about it when you're a patient and you're trying to plan what to do with your tumor during the surgery.
I remember what I was going to say. The other consideration is, does the tumor change over time, right? Does it evolve over time? So are you getting an accurate picture of, that moment in time when you sampled the tumor at initial surgery? Does that accurately reflect the tumor biology when you might need systemic therapy down the road? Josh, did you have a question?
Decalcification front. So having just undergone surgery this front of mine, it wasn't exactly clear how that got done or what was that part of a standard workflow or process. So we've heard some other patients who were hoping that they were to be able to have sequencing done and the tumor was decalcified was very disappointing. So at what point in the process can other patients ensure that their tumor is not decalcified? Is that a conversation with the surgeon? Is that a conversation with the pathologist? How does that?
Yeah, that's a good question. It's a conversation with pathology, and a good pathology department should not decalcify. So the process of decalcification happens so you can actually process the tissue and cut it for diagnosis. So it's nothing inherently evil about decalcification. There are bone tumors that you just cannot process without decalcification because the calcium will basically prevent processing of the tissue. So there could be parts of the tumor that just simply need to be decalcified because there's a piece of bone. For us to see whether Cordoma is growing into the bone, we need to decalcify it. But it's very important, and I would say most of the good pathology departments know that the soft part of the tumor should not be decalcified, because if it's not needed to be decalcified, it should not be decalcified. The problem is, the devil's in the details, and what sometimes happens is it's a bone tumor, so some technician just drops acid on everything and just decalcify the whole thing, right? And that's where these things happen, that nothing remains decalcification free, and you can't walk it back because that decalcification destroys the DNA and RNA forever, and there's absolutely nothing. It doesn't destroy the proteins, so there is a hope that if we identify some biomarkers using DNA and RNA, we can still test the proteins on decalcified tissue. So it doesn't close all the doors, but it closes many of the doors.
Okay, I think we can do one more question, and then if anybody else has further questions, feel free to catch up with us after the session.
Okay, Dan, I just want to ask a question about what the Cordoma Foundation is doing in terms of being able to preclinically test immune therapies, because there's been a lot of success with immune therapy combinations with targeted therapies.
Yeah, thanks for that question. So there's a lot of excitement in immunotherapies currently, and it's one thing that has been front of mind for us is how to test immunotherapies and immunotherapy combinations preclinically, so we can kind of model what the most promising options are for chordoma patients. And so recently, just in the past year, we've developed what's called a humanized mouse model of chordoma that gives us a platform for doing that. So that's one way that we're doing this. And so usually when we model chordoma in mice, we have to destroy their immune systems, or almost completely destroy their immune systems, because otherwise it will recognize the human tumor as foreign and reject it, right? So you can't grow it in mice. But there's a way to essentially humanize a mouse, which is to reconstitute a human's immune system or components of a human's immune system inside the mouse. So it's a human immune system that's recognizing a human tumor, and in certain cases it will not be rejected. And so we've created that model for that exact purpose, to be able to model immunotherapies. And just real quickly, another thing that we're doing in our new lab is we're hiring actually for a new position right now, where we're going to have a second scientist join that has experience in in vitro or test tube experiments that combine cancer cells with immune cells and drugs. And you look to see, you can do certain types of experiments that essentially assay for immune cell-mediated killing of chordoma cells in a dish. So that's something that is front of mind for us, certainly. More?
I've signed multiple consent forms before surgery for research. One is as late, I was just getting ready to go into anesthesia and they handed me a clipboard to sign it at the last minute. But my question is, does that stay at the hospital, or does any of that make it to the Cordoma Foundation?
So every one of these forms is hospital specific and program specific, and it really depends what the research program is happening. You can always make your tissue available to other researchers, and you can request it to be sent to other hospitals for research through the material transfer agreements. But if you have, for example, a very active tumor banking, like we have at NYU, you basically sign a banking consent that we can bank the tumor on normal blood, and we can store it in a bank and then use it for research. Or there can be a larger effort, let's say through a Cordoma Foundation, that the investigator locally is allowed to develop a cell line, and then those cell lines to share among other researchers who work on this problem can be shared as well. So those are different things. But even if you're a Cordoma patient that did not sign any research consent, you can still arrange your tissue to be sent either to Cordoma Foundation or to other researchers who work on a Cordoma. It just requires a lot of paperwork.
Yeah, and sorry, I think I understand your question now a little bit better. So yeah, we do have a tumor donation program. So you can sign, we have an IRB approved protocol that has its own informed consent form that would allow you to contact us and arrange for that tumor to be sent to our biobank. It would be a separate form that you would have to sign with us, but then you could arrange for the hospital to send some of that tumor sample to us for research if that was something you were interested in. So we can chat about that later if that is something that you're interested in. Okay, great. Thank you so much, everybody.